Thank you very much for having me speak today. Excited to share some of the updates that we have in terms of our management of CNS astrocytomas. So here's a little bit of a background. The condition has changed over the last decade in that we're really focusing more on the genetic components instead of just the imaging characteristics. And that's allowed us to really focus on improved treatment options in the long term. So once we do the surgical resection, we're aiming for super maximal resection as long as it's safe to do so. And so that depends on where the motor strip is located, as well as speech areas. Or within the brainstem, we'd have to target it more for chemotherapy or radiation. Depending on where the tumor is, we can do the surgery either awake or asleep. And we frequently do motor mapping to ensure that we're getting most of the tumors out. We're using some fluorescent dyes that are injected to make sure that that's lighting up the area of tumor. So the dye goes to highly vascular areas. So once that area is depleted of the dye, it's a pretty good indication that we've gotten most of the tumor out from that region. Once we do the surgical resection, there's different options. Temozolomide has been a standard of care, as well as some other chemotherapeutic options. At our institution, if it's a small lesion, we will typically do stereotactic radiation to the resection bed to try to increase survival. If there is extensive expansion, we can advance to whole brain. But we'll go into a little bit more of like the data from patient populations and some new treatment options on the horizon as well. So this is the overall incidence of astrocytomas by region. Western Europe, US, Canada, Australia have a little bit higher rates than Asia and Latin America, but it still is an important condition across the world. There are several different types, and they are graded by how invasive and aggressive they are. So you go from the pilocytic astrocytomas, which are much more common in children, as well as the SEGAs, which also are pretty common in children as well. And then you can start advancing to the diffuse astrocytomas, the pleomorphic xanthrocytomas as well, which are focused primarily in the temporal lobe. These are a little bit slower to advance, depending on the location and the symptoms associated with it, would be candidates for surgical resection. Some of these are monitored over time if they're very slowly progressive and depending on age. And then the common types that we frequently will do surgical resection with right up front are the anaplastic astrocytomas, which have a high rate of progressing to the stage grade 4 glioblastomas, which is the most common in terms of our astrocytoma profile. So our diagnostic capabilities are primarily MRI based. So we're looking for this homogeneous mass for the low-grade astrocytomas. There's going to be little vasogenic edema. There is going to be high ADC on our DWI. And then if we do more of the spectroscopy, these have the low choline, low lip-black creatine ratios. Compared to the high-grade astrocytomas, these are very strong contrast enhancement. There's often area of central necrosis, so they're pretty classic features. Other tumor types that can look similar include lymphomas. There's also tumor-factive multiple sclerosis that can look similar as well. Those three conditions are the only ones that cross midline in terms of tumors, so it can really help us differentiate. But by and far, when we see those imaging characteristics, most likely is high-grade astrocytoma. So this is going a little bit more into our resection. The subtotal resection is if we just pretty much evacuate the cyst, so that necrotic core. We take some of like the enhancing REM, but don't get a complete REM. Our goal is to aim for at least gross total resection. So we use those fluorescent markers. Sometimes we have our intraoperative MRI as well to really enhance that surgical resection. And if it's safe to do so, as you can see here in the frontal lobe, we aim for the supramaximal resection. The flare signaling changes with the edema have really shown that there's tumor infiltrate within those edematous regions. So the supramaximal resection, if it's in a safe region, has increased life expectancy. And going towards the genetic diagnosis, we're really looking at the messenger RNA sequencing to try to streamline patients into the appropriate treatment options pretty early. Our group has found that there's an iron enrichment score that has pretty good indication of overall survival analysis and can really help with differentiating into appropriate immunotherapies. So that has been helpful in stratifying some of the patients. And as we'll go through the talk, will really be the next phase of how we treat patients going forward. So this is the standard treatment with temozolomide. So we have active MGMT with the live cancer cell. And so this shows when it's inhibited, you can have cancer cell death. So for those specific cell types where the methylation is in place, has great efficacy. But we're really getting to the point where we're transitioning more to personalized medicine, taking the whole genetic landscape and really targeting treatments more effectively. And so instead of these broad-reaching approaches, we're really trying to target mechanisms a little bit further. And so this is really showing like some new treatments in terms of targeting the DNA damage repair mechanisms, specifically for those patients that have specific mutations that are not classical for the temozolomide treatment. This can increase survival and have ultimate benefit for patients. For those regions where it is exceptionally hard to treat, so within the brainstem, the surgical resection is not an option in terms of a safety profile. Radiation also is not a great option because of the close proximity to cranial nerves. So we're really left on really targeting the specific molecular pathways to try to decrease progression. And part of this is really understanding the molecular basis. So there's some new treatment paradigms that are really targeting these brainstem gliomas, having some pretty good outcomes so far. It's still in its infancy, but some of these treatment profiles are improving patient survival. So this is a Kaplan-Meier curve showing that there is increased survival scores when we use that iron enrichment scale to really funnel patients into the appropriate treatment paradigms. So in terms of tumor sample metadata, you can see that slightly more male than female. In terms of the astrocytoma versus glioblastoma, both of those were higher compared to our oligo dendrogliomas as well as our oligoastrocytomas, which is pretty standard for the literature. Vast majority received radiotherapy as well. As I said, most of this was SRS based to that residual tumor resection bed. And then we did the further genetic analysis from there. So this is looking at the overall pattern of the iron-enriched gliomas, showing that there is very specific subtypes that can be grouped into specific treatment options. We'll go into some of those treatment classifications, but this is really showing that it is feasible to really transition more to a personalized medicine state. This is another analysis of individual patients showing that there is high heterogeneity in terms of the overall molecular profiles. Each patient has individual genetic mutations as well as overall arching pathology. So really showing that subset analysis is going to be more important in increasing survival for this patient population. So we'll go into some of the developing treatments right now. So we have some of these small molecule inhibitors. They're really targeting the CDK4 and 6 pathways, some of the proteasomes, as well as the tubulin associated, having some good results for those subset of patients. There's some new histone deacetylase inhibitors, which for those specific populations have increased survivability as well. And then something that is very exciting and our group is working on is the CAR T cell-based therapies, really targeting the molecular pathways, more specifically increasing the immune response to cause increased apoptosis and engulfing of the tumor cells. So it's in its infancy. There are several groups across the world that are working on this, but preliminary data is pretty promising that it will have some meaningful effect. There's focused ultrasound, which is going to be pretty exciting. So the way that it works is that there's a high-speed ultrasound that will be placed on the surface of the scalp. It disrupts the blood-brain barrier right over that region of where the astrocytoma is located, and then that allows selective penetration of chemotherapy across the blood-brain barrier. So it should continue to improve outcomes. As an endovascular neurosurgeon,